Okay, you ready? Okay. Good evening, everybody. Gary, could you close the door, please? Good evening. My name's Cliff Weiner. I'm president of POA. First on our agenda is we're going to stand for a pledge to the flag and then a moment of silence. Thank you. Please be seated. This meeting is gonna be a little bit different than most of our meetings. For those of you that come all the time, we have two speakers. So we're gonna dispense with everything except the cash raffle and what I'm gonna tell you now about the shredding event, which is coming up on April 20th at New Covenant Methodist Church. You need to be a paid member with your dues current on the day of the event. You need to send me an email if you wish to receive a shredding ticket. No ticket, no shredding. With that being said, we're going to draw 3 numbers. We're going to give away 3 $30 prizes. First number, last 4 numbers, 3748. Gary. Sure. Huh? Well, I don't have them. They don't allow me to hold the money. $3817. Okay, just Jerry got one here too. 3743. Okay, you got one right here, and then one all the way in the back. Okay. With that being said, our first speaker is our district manager, Kenny Blocker, who's going to introduce the person that's going to do the presentation, Kevin. So, Kenny, you're up.
Good evening. Thank you, Cliff, for allowing us to come out on such short notice to give this information out to your membership.
Can I just say something
Yes,
so
sir.
they understand?
Yeah.
Kenny's got 15 minutes to do a presentation and 15 minutes for questions, and I will hold them to the second. Thank you.
Very good. So without further ado, to get this thing going, because we have limited time, I'm going to introduce Kevin Plensler from PFM as our consultant who put together the assessment methodology for, as you know, the new fire assessment that the dependent district is looking to approve. So with that, Kevin?
Thank you, Kenny. Appreciate the crowd. I won't let it go to my head. So, and I'm on the clock. I will be fast, but not in a hurry, as best I can. So, as Kenny mentioned, here to discuss the preliminary analysis for the Fire Rescue Service Special Assessment that is currently in process of being worked on and eventually adopted by the VPS DDD board. I won't. With respect to, let's see, I can't really see the slides. Could you move to slide 3, please? Or actually, I guess I'll move it to slide 3. All right. So with respect to the district, because it is a dependent district, then by its very nature, a special assessment is required versus a tax. And we'll discuss the difference there. But ultimately, there are many ways to do a special assessment. It just needs to be reasonably and equitably allocated. And ultimately, there's a pretty wide latitude with respect to those that parameter. But our goal, ultimately, with respect to this methodology, in understanding the nature of the fire rescue service was really to allocate assessments to each parcel and land use based on its relative benefit received via its access and utilization of the fire rescue service. So we'll go into kind of how we develop that over these past few months. That begins with a analysis of all the parcels within the VPS DDD, and I'm going to jump forward a couple slides just to show you the scope of how big this district is. As you can see there, it's a pretty dramatic boundary. It is a large portion of Sumter County in terms of the analysis conducted, and that involves an analysis. It involves an analysis of approximately 67,000 different parcels within the district of various shapes and sizes and uses, residential, non-residential, vacant acres, and also a host of other types of properties, churches, schools, nonprofits, etc. So our analysis involved going into detail, identifying each of those parcels, their square footages, their acreages, number of residential units, etc., within the district so we could properly determine the nature of the uses within the district. In addition, as part of the analysis, worked with the VPSD staff, and they did a detailed budget analysis and identified the capital and operational costs necessary to provide the fire and rescue services over the next 5 years. And in that analysis, there was an allocation of budget between essentially dollars associated with readiness and dollars associated with demand for service. And that's really incident response activity. And we'll get into that a little bit deeper here in a few minutes. With respect to a special assessment, like I said, it's not a tax. And by virtue of statute, we have to pass a two-pronged test for special assessment. And with that, there's the property assessed must derive a special benefit from the service, and the assessment must be fairly and reasonably apportioned. As mentioned, under Florida law, local governments are afforded latitude regarding the legislative determinations of special benefit and reasonableness of apportionment. But that, as you can see in our analysis, what we've done here in breaking up in terms of readiness and demand was our approach to trying to do our best in terms of allocating those dollars to the parcels that are utilizing the service for both those elements of the budget. With respect to the demand analysis component, we looked at 4 years of an incident response for the fire rescue service, and broke down that data into essentially when the phone rang, where were the fire rescue responders going, what type of properties did they visit. So that informed us as to how to allocate essential dollars to the utilization of the service. We also gathered data from the Villages Development Company that provided the forecast data with respect to future development plans for the next 5 years in terms of the residential and commercial forecasts. So that includes all age-restricted development and non-age-restricted development forecast, as well as any additional non-residential development, retail, office, hotel space, golf courses, etc. All of that has been incorporated into this analysis going forward over the next 5 years. And based on our analysis, we were recommending adopting a 5-year average rate that would smooth the annual rate variance from year to year. So ultimately, we weren't getting into a position where the fire assessment, a special assessment, was moving year to year. We're going to set the rate for 5 years based on this budget analysis. And that would give some price certainty for that assessment going forward, knowing at the end of the 5 years, an updated analysis would be required. So for those of you with the handouts who can see the small font here behind me, the readiness, the budget essentially over the 5-year average is just under $25 million broken up into two components, a readiness availability component and a service demand component. So if you think about it, similar to potentially a utility fee, your readiness availability is essentially your base rate, and your service demand is your actual utilization. So if you have irrigation services, you're really paying for what you use on that service demand component. The readiness availability is your base rate. So for the readiness availability component, that is allocated across all parcels, regardless of how big or small a parcel is. Essentially, if you are a parcel within the district, you're going to be allocated your portion of the $17,000 or $17,450,000 in change, and that's just a simple division. The service demand component is a function of a weighted analysis in terms of allocation to the end users of the service demand budget component, and that is based on an allocation via ERU. And an ERU is an equivalent residential unit. So that converts non-residential square footage into essentially a set of units. So if you picture a 10,000 square foot facility, you divide it by 1714, and you'd get approximately 5 ERUs for a 10,000 square foot commercial center. We're aware that there's been some discussion regarding impact fees. Note that the VPS-DDD does not have the statutory authority to issue an impact fee. That power resides with the county. And impact fees are essentially built around paying for net new capital improvements. And we did a brief analysis of the budget provided by the chief in terms of their capital needs over the next 5 years. The vast majority of those costs are replacement costs for existing facilities. So ultimately, the vast amount of capital costs would really not be subject to impact fee dollars. But ultimately, we wanted to just vet those assumptions accordingly, noting that an impact fee, if the Sumter County desires to do that, would then impact how the VPS-DD would budget going forward. But that's something that we have not incorporated into this analysis at this time. As mentioned before, we did our analysis of the 4 years of data with respect to incident response. Provided the following results. You can see here that the vast majority of fire rescue response and incidents were to residential units. The second most response were to healthcare facilities, predominantly nursing homes, followed by commercial space. And then some ancillary uses there to the other end users there via the property appraiser category. You can see in there's some uncategorized responses. Think of those as responses that would be going to the fire chief response to a car accident on the turnpike, and there's really no end user there to put it in terms of property appraiser analysis. We excluded those data from our analysis, and given the large sample size, felt very comfortable with respect to the allocation to the end users here, with respect to the allocation of the demand component of the budget to these end users going forward on an ERU basis. And lastly, with respect to rate setting, as mentioned before, the rate setting is assumed to be setting a 5-year average proposed rate for the various end users. And then this incorporates all the anticipated growth as provided by the villages, and also incorporates, will cover all of the capital and operational needs as currently budgeted by the VPS-DDD. Note that this analysis is still preliminary. There's a little bit more data and research going into the properties within the district that would be subject to the special assessment, as well as some additional analysis with respect to the budget. But I'd say we're at a 90 to 95% document. There may be some tweaks here to the analysis, but ultimately they're pretty close to final. These tables here provide a summary of our findings to date. So you'll see here that residential assessments are provided on a per unit basis and do not vary by unit size. So as we discussed the ERU factor, that is not applied to residential units. So if you're a 2,000 square foot home and your neighbor is an 1,800 square foot home, you're going to pay the same fire assessment fee. We're not allocating that on a square footage basis on a unit by unit on the residential side. With respect to non-residential square footage and vacant land and acreage, those are allocated on an ERU basis. So the top table, the point of this table here is to show the allocation and analysis and to show the comparison between essentially one unit of the various categories. So a residential unit shown here has an estimated fire assessment fee of $333.26, And then if you took the same commercial square footage and converted it into an ERU, they'd be paying $380.43 per unit, and so on and so forth through the various categories here that we put together. And this is really just to show a comparison of unit to unit along the way, and we'll have some additional comparisons here along the way as well. Down below, you'll also see how a change in square footage, if you compare the retail commercial 10,000 square feet to the industrial 25,000 square feet, they're essentially, those are both quote-unquote commercial categories for purposes of our analysis, and you'll see that the larger square footage facility pays a higher fire assessment based on its demand component applying the ERU factor. The readiness-based fee is the same for all parcels regardless of use or type. That's just a parcel-by-parcel component. And so you can see that there's variability with respect to the demand component via size, but not on the readiness component. With respect to these set of tables here, on the top table, we did a broad-based analysis of comparing the estimated current fire fee compared to the estimated fire assessment fee as proposed in the special assessment. You can see here that the vast majority of land use codes, when you kind of look at the categories there, are going to see a net reduction. There are increases really as a function of two components, one being utilization of the service when we compare the fire assessment fee under the VPS DDD compared to the current fire fee. And then ultimately there are elements where if you are essentially a very, very low taxable value property that may have a whole host of exemptions, your fire fee would have been weighted much lower than the fire assessment fee as contemplated using the readiness and demand analysis. You can see that down below in the table below. So you'll see here in the current funding, the current fire fee is a function of two elements. There's a fire fee, which is $125 per unit, which is the fire fee that Sumter County charges. Also embedded within the ad valorem tax that's paid, approximately 1.31 mils of your taxable value associated with the current county runs to the pay for Sumter County Fire Rescue Service. So when you add those two elements together, you'll see a total fee there for the various taxable values. Down below, you'll see the proposed funding taxable home value and then the proposed VPS DDD assessment, which has the readiness base fee plus the demand fee for residential, which are all the same. And then we also have an ad valorem offset, and I'll get to that component later. There's a small ad valorem component that we'll touch on that is associated with parcels that are exempt from assessment. But you can see here, under this scenario, there are savings to the units in terms of this proposed funding compared to the current fee. And note that that's associated with just the fire rescue services that we're comparing as a best apples-to-apples comparison here. Similarly, we did a similar type of analysis for commercial property, showing the current funding versus the proposed funding. And you'll see on the savings per ERU, they're generally consistent with the savings on the residential basis. So the very last column here on this table, you'll see savings per ERU, which is really a savings per unit. And that compares generally consistent with the savings on the residential side on the previous table. Lastly, for rate setting, there are exemptions. By Florida statute, there are certain properties that are not subject to special assessment. Chapter 125 of the Florida statutes exempts agricultural lands. That does not exempt agricultural lands with residential properties or with residential units on them. So if you are an ag land with homestead exemption or ag land without homestead exemption, that suggests you still have a residential unit, you are then classified as a residential unit for this analysis. The other ag lands are exempt. So you'll see the various land use codes that are agricultural, 5300, 6900, 6000, are all exempt from special assessment. Similarly, any county, state, federal, municipal lands also excluded from special assessment. And lastly, for purposes of exemption here, we have exempted churches, schools, and nonprofit facilities. And specifically, we identified a handful of nursing homes and hospitals that are 501c3 nonprofits, which we deemed exempt for purposes of special assessment. And the net total of that suggests that just under $600,000 of special assessments could not be collected from those subset of properties. Ultimately, though, we're not allowed to just take that $600,000 and reallocate it to the populace here because you're not benefiting from those services. So the way to capture those dollars is via just a standard ad valorem millage assessment. So currently, the estimated taxable value of all the properties within the boundaries of the VPS DDD are $16.8 billion. So when you allocate that's just under $600,000 to those properties, it results in a taxable millage of 0.034 mils that would be put on the tax bill to offset those exempt properties.
Kevin, time's up. How much more do you have to finish?
I think I have one slide.
Okay, please finish.
I tried. Important dates. This is, like I said, this is the preliminary analysis. April, the methodology will go before the VPS DDD board for them to consider and adopt the form of the methodology. At the June meeting, a public hearing will be held, approving an assessment roll, which will detail all 67,000 parcels within the VPS DDD and what the fire assessment would be. And in September, that assessment roll would be provided to the Sumter County Property Appraiser, and ultimately that fire fee would be placed on your November tax bill. And typically, you'll have your city, county, taxes, et cetera, and there'll also be a line item there that will then show a non-ad valorem assessment for fire and rescue services, and that's where that fee will be shown. So that's where it'll be. It'll be on your tax bill in November.
Okay, questions? And I'm going to ask if you're a POA board member. Please do not ask a question. I want the questions to come from the audience. If you have a question and you're on the board, send it to me and I'll get an answer for you. Raise your hand if you have a question.
Got a couple questions for gentlemen, and thank you guys for coming here. And although I'd love to get a copy of that so we could actually see the numbers. Is there a copy back there? Thanks you, Kenny. Couple of things is first slide showed the map of the district. Who exactly made that map? Because it existed back for the independent district, and it's best I knowledge it's the same one. Is that true?
It probably is exactly the same one, but that was all in the ordinance that was approved by the county commissioners.
I got you. Who made the map? It wasn't made by the BOCC.
It was in conjunction. See, it says Source Sumter County. They did make that map.
No, that's the source of where you got that map. I'd still like to know the exact person, and I'll ask Brad Arnold, but I don't think that's the case.
Okay.
Because this includes a fair amount of commercial properties along the periphery of that, and that's the other question is that the methodology you guys just presented doesn't take into account the uniqueness of the commercial properties. Fire response, for example, to a multi-story building requires tall ladder trucks that are twice as expensive. The residents don't really need to pay for that. We all have one-story buildings.
Let me have the chief answer that question for you.
So how do we account in the methodology for paying for this commercial? Hazmat, for example, all the dynamite down in the mines that are included in this map. Do the residents need to pay for the hazmat?
So to answer your question about ladder trucks, there is a misnomer that ladder trucks are only used for commercial buildings. There is quite often that we use ladder trucks on single-family dwellings. We get there, they're well involved. We will put the ladder truck up because we can put out a lot more water out of it and contain it to that structure. We use the ladder trucks to get people off roofs, for example, when they're having a heart attack, stuff like that. So there's multiple uses other than just buildings, tall buildings for the ladder trucks. And then we also have the ladder trucks, obviously, because of ISO ratings, which say that we have to have X amount of ladder trucks in areas where we have buildings that are 3 stories or higher. And as far as
hazmat.
as far as the hazmat, we have Sumter County has the hazmat team in the area. We also have mutual aid agreements with Lake County and Marion County as far as the hazmat, if there was to be a hazmat incident at one of those locations.
Again, I want to thank you for coming and giving this presentation. My question is, in the document, you refer to all residential properties are taxed at the same rate. So if you have a 1,700 square foot house or you have a 3,500 square foot house, they're paying the same rate. My question is, the Sumter County property assessor doesn't charge me the same rate as someone who has a much larger house. So why are you doing it and the property assessment guy is not doing it that way?
Because of the very nature of a special assessment versus a tax. A special assessment, by its very nature, has to prove the benefit associated with the property, and it's not a function of value. The special assessment is a function of utility and benefit, and that's a different metric by which an assessment would be done. A tax can be done however the taxing authority wants to tax you. A special assessment cannot look like a tax because then it really doesn't become a special assessment. It becomes a tax. And by virtue of the two-pronged test that we have before us, by state statute, I can't turn a special assessment into a tax the way the property appraiser can, or the county can.
Okay, time's up for questions. I want to thank Kenny, Chief Twist, and Kevin for coming and doing this. I will tell you that on April 4th, we have a meeting in Everglades. We have a speaker, but they are also going to do this presentation again. So if you still want more information, come there. Maybe we'll have more time for questions. It's important information. Thank you, guys.
Appreciate it.
Our next speaker is Cheryl Chestnutt, who is in charge of the Villages Hospital. And I got to say that I've been here 22 years. I've been here since the hospital started. I toured the hospital on its grand opening. And this is something that's really kind of important. In the last 6 months, I haven't got one complaint about the hospital. Now, I'm sure there's still complaints, but I used to get one every week. That's gone away, so I think they're doing a good job. I'm really looking forward to seeing some of the things she's done since last year when she was here, and hopefully she'll agree to come next year and tell us more things that are going. So, Cheryl, you're up whenever you're ready. Mike's got to hook you up. And Cheryl does not have a time limit, so whatever her talk is and whatever the questions are, she will stay and we will answer
Well, it's past
them.
my bedtime,
Oh.
so.
Just
it's
like all the
kinda
rest
late.
of us villagers.
Yes, it's kind of late. Was starting to think that it was me, and it was time to go. Thank you very, very much. Thank you, Cliff. I don't see, oh, there he went. Thank you, Cliff, for having me back this year. It has been a full year since I was here, and I am thrilled to be back again. I do have to watch my words tonight because last time everything I said ended up in the newspaper, in my driveway, and it was kind of scary to see what my words are, so I will try to be careful tonight. It is also thrilling. It is the only time in my life I don't want to be number one, and I was very pleased to see that I'm not number one on the watch list this year. So thank you, Cliff. I'm number 4. So thank you for that piece. Okay, so let's get started. Last year we talked a lot about the team, about the leadership team quality. We talked about outcomes, talked about many things. We will also talk about that tonight. We will talk about what is going well, and then I'm going to end it on what is our weak point and what we are trying to do about it. And then at the end, of course, we have questions where you can ask me what you would like. So first of all, the team. I am absolutely nothing without my team. I have the most amazing team that I actually sometimes, and just in all of them, they have really come together and they share the vision, which is really to be a 5-star facility. It is also not just that, but is also to make sure that everybody that walks within the front doors, receives the best care. So this is for the team. And last year we had talked a lot about how short-staffed that we were, how the pandemic had really, made it difficult just for healthcare. But I do have some good news, this year. You can see, and it's kind of hard for me to turn around, but I'll just read it off of my slide. You can see that in the last 2 years that we have decreased nursing turnover 47%. We were at 37% in March of 2022, and we are now down to 19.9. This is really, if you think about what happened during COVID, 1 million healthcare workers left the acute care space, not just here, but also across the nation. With this as well, I think, that it goes into the hiring piece. Last year, I had talked about hiring, international nurses, local nurses, anybody that wants a job. Any of you that want a job, see me after. I've got business cards. So we have hired, but I really think it comes down to, first, we have to have leadership, or had to have leadership, and really had to start to work on the culture piece of those that came to work. Like I said last year, that if you don't want to be a nurse, if you don't want to give great care, this is not the place for you to be. So we have hired 428 RNs, which is a 28% increase year over year. In our techs, 138 more, which is an 84% increase. If you think about that, I think back to last year at this time, we had beds closed. I had hallways closed. If you know the hospital, there's A, B, and C hall. There were actually beds and halls closed because of lack of staff. Last year, we were also really staffed a lot with travelers, which are extremely just expensive. $105, $120 an hour, and their output and quality is not what we would like for it to be. When I started in September of 21, we had 90 travelers, and that was with beds closed as well. So I actually had just about the same amount as full-time staff as I did those that really came from just across the country to make money. This past year, we went down to 43, and I'm thrilled to say that as of today that I have none. I don't plan to have any again either. I think it is best. We have done a great job hiring, and that really comes to my team, and really just hiring, loving them, and just moving forward. I think that one other indicator that makes me feel really good that we are on the right track is the vacancy rate. that the national average for healthcare, acute care hospitals is 12.7%, and we are at a 9.8. And I think that speaks to just the tremendous work that the team has done over the past year. Next is starting to expand the footprint. Everybody wants to talk about Brownwood. Everybody loves to go to Brownwood. So we only had 16 beds before. They were very, very smart when they built it three years ago to build a shell space. They did not think that we would need to build out the shell space for about 5 years. Well, it's already built out. We have added 12 more beds, and it is just the craziest thing. We have been averaging, 50, 60 patients, and within the last 2 or 3 weeks after that, after we opened the other beds, we are actually averaging 70 to 80 now, which is great for us, which is also great for you. So everybody wants to talk about what is the difference between Brownwood and then the Villages ER. So I just figured that I would talk about that. One thing is those that go to Brownwood, many of them are walk-in, and many of them are able to go home after. So let's say that those are less acute patients. Only about 10 to 12% of those who actually get seen at Brownwood have to stay and have to go to Leesburg and or the Villages. Many that go to the Villages Hospital are actually much more ill. And there's about a 35 to 40% rate that if you come in that you are that ill that you would have to stay. So that's the difference, I think, between a high volume of walk-in at Brownwood. So I would say to you, if you don't feel like that you need to stay and you may have something minor and you want to go to Brownwood, it's a great place to go. They really want to get you in and out quickly. And you may say, well, what about more growth? We are looking at possible more freestanding urgent care models within the area. We do have some property that is outside the yellow line, but more to come on that within the next year. We have started ground on a new freestanding urgent care model out in South Lake County. And you may say, well, what does that matter? I think that if we look at the growth for us, we are going all the way down to Lake County. We will, just continue to grow. This is a also highly active growing area, just like it is here, and we will continue to push. And then, of course, we talked about this last year, the mobile stroke unit. We had our gala last month, and we are poised to begin operation on our new mobile stroke unit. And for those of you that have not heard, or if you do not remember, it is really a special, small designed hospital on wheels that helps to, reduce the amount of time from the onset of a stroke symptom to getting you the care that you need. We have purchased it, and I believe that we should have it in September, and hoping to go live by the end of this year. And those of you that we serve, for us, it's important. I think the first 2 years, COVID really did a number on us, but it is time for us to be active within, the area that we serve. Recently we had a heart-to-heart, meeting, really trying to raise, just awareness on heart care. And then also you will see us at all of the running of the squares, but we had a good time. And in fact, I don't have it up here, but for this past weekend, we were actually at the Parkinson's Walk. It is something that is very near and dear to me. If you or somebody that you love has Parkinson's, you should receive the best care when you're in the hospital. I was told recently, probably within the last year, that the most unsafe place for an individual to be with Parkinson's is in the hospital. Not just our hospital, but just any hospital. And so we have really partnered with them, trying to figure out ways to make sure that we know which patients have it, and to make sure that we are, getting them out of bed as well as getting their meds timely. That is a very important thing for us. So it goes beyond walks. I think it's partnering as well. Also, if you know Dr. Alvarez, she is a woman who loves to treat women and likes to prevent heart disease. We do a lot of work with her, and then also Dr. Collins is our new orthopedic surgeon. He came from Sarasota, so if you haven't met him, he is also new. Now, we talked about this last year quite a bit, growing. How do we grow the network? How do we grow those that are employed by us, that we have a large amount of just community physicians, but how do we start to grow those that we actually employ, because it's easier for us to connect you with them, as well as to ensure quality outcomes. You can see that at the top, and I'm not going to turn around and look at it, but the two big things I'm always asked is, what about primary care? What about primary care? And up until recently, well, we didn't have any. We now have two. So we are looking to put their offices in Summerfield and as well at the villages. And I think that's a big piece for us. It is the one, market that we have not tapped into. The next one is surgical and really breast care. Dr. Hockey actually just bought a house within the villages. So he is not far from here. Really was a general surgeon most of his life, but went back and specialized in breast care. So he's just starting his program. Critical care. I had also talked about this last year. Back in October, we now have a critical care provider on site 24/7. So that means that if you are critically ill, that you can make sure that there's somebody that's on site to take care of you or your loved one. That's important, for outcomes as well as it helps to meet the need for leapfrog. And then, of course, these are the areas that we are really trying to grow: GI, neuro, primary care, uro, spine, orthopedics, and then also cardiovascular. It is not always the easiest market to try to recruit. And yes, there are, just like with any, industry, there are challenges. If you are employed by UF Health, you actually work for Shands, and Shands employees are not eligible for charter school. So, having younger families here that have the younger children, many of them go to Mount Dora Christian, or they go all the way down to Tampa for their kids for school. So that is something, that we, just continue to try to work through. And then the last part is where we'll probably spend the most time, and I'm sure that we'll have the most questions. It is, how are we doing? Last year that we talked about quality quite a bit, sepsis. I can't tell you, we have met goal for many, many months. Hospital-acquired conditions, which are that we don't cause trauma to you if you fall. We don't give you infections. We are also meeting goal. I really wanted to highlight really the just tremendous work that the team has done around the ER. I think that when I started, that the number one thing I heard was that ER. Oh my goodness, what are you doing about that? That is such a disaster. And in many ways, I can understand what the comments were. So over the last year, and I had talked about this last year, quite a bit, that we had to get the ER right. It is not perfect. I'm not here to tell you today that it is. But having the ER right just allows us to be able, to start the service of you when you come through that front door. So when we look at the bar graph, this is our admit time to bed. So this is the ER. So you can look at Q3, Q4, 22. So this is minutes, actually. So 867. That's 14.4 hours it would take us from the time you needed to get a bed till the time we could get you a bed. This was fourth quarter of 2022. I think we all can say that that's not acceptable. I can understand why people were mad. I can understand why we sometimes had 20, 30, 40, 50 people waiting for beds. Like a lot of it was because we had beds closed because we didn't have staff. I am happy to say that in fourth quarter 2023, we're down to 1.7 hours. So by the time that you get a bed or that you need a bed, that we can give you a bed. I think this is just tremendous work, and it has been one of the things that has driven the work for us. Last year, we went on, I don't know if you've heard of it, diversion. So any time that we got really, really full within the ER, we would have to turn away ambulances. We would have to put up a flag and say, sorry, we can't take more. But if you walk in, well, we can take care of you, but we can't take care of you if you come within an ambulance. So we turned away a lot of patients in the last, I don't even know, 5, 10 years because of that. I finally said, no more. We have to be able to take care of our own. And I'm very happy to say that we have not had to go on diversion for 6 months. If they want to go on diversion, they have to call me, even if it's 3 a.m., so they don't call me, because the answer is going to be, no, let's figure it out. Let's get everybody on the phone. What do we need to do to rally to get the troops going, and let's get this done. I am thrilled to say that we are in March. We are in season. We are actually 15% over where we were last year for our hospital census. But you wouldn't know it because I have every bed open with a staff member. And sure, a week or two ago, did I have 10 holds? Yes. It was just, we were at the seams. But within 2 or 3 days, we were able to clear them out. I actually walk once a week, and I start to take pictures of things that I like and things that I don't like. I saw some stuff on the floor today. I took a picture and said, come and clean this right now. I didn't say it like that. I was very nice. But I also took a picture of the ER lobby at 9:30 this morning, and it was empty. That made me happy. So that's a very good thing. But the one piece to this has really been just a combined effort with the metric next to it. So the inpatient world has done nothing but move, trying to expedite the care of those that are in the beds, trying to reduce the time that a patient spends within the hospital so that we can move up the patients from the ER. So we have saved 0.6, so over a half a day within the last year. And that equates to 25 more beds each day for us. I won't even talk about the money piece to it, but to get you home earlier, to not waste your time there in the hospital, it actually provides safer care, because the longer that you stay, the more we may do to you. That's just a national fact. So the goal is to get you out as safely as we can, and as quickly as we can. So our goal really is to drive down to one day instead of the 0.6. So we are trying. And I do believe that this summer we will get there. I have a fantastic team that really chases doctors. And if you've been there, well, then you know that the doctor tells you you can go home, but you don't discharge, for 4 or 5 hours. It is not perfect at this point, but we chase and try to do everything that we can do to get you out. The next piece is this probably looks good, but this isn't something that I'm all that proud of. These are wonderful comments. And so this is the most important slide of this entire presentation, and it's the voice of those that we serve. These are all very nice things up here, but this matters. This is where we have failed for many years. It does not get fixed overnight. This starts with trust. We are starting to build trust. We are not there. This is hard because this will take time. This actually is what is in the way of us being 5-star and Elite Frog A. So that's not the only reason why that it matters, because we have fixed everything else. We are not perfect though, but this piece is the hardest mountain to climb and will take time, and it is because of all of you that we continue every single day. Every single day, I look at Google, I look at Nextdoor, all of you that put stuff on Nextdoor. I take screenshots. And then if it's negative, I try to figure out who it is. Sometimes I can't, but I've got the yellow pages. I do look, and then I do go back and try to figure out, but sometimes it's a friend of a friend, and it is not to call them, to make them defend anything, but it's to understand what could we have done better. And I also committed to you last year that every patient should see a leader every single day. I'm at a 95% rate of that right now. So when I get a bad review, whether it's a written piece of paper, whether it's Google, whether it's Nextdoor, Facebook, I will go back and we look up the log from when the leader went into the room, and I try to figure out, what did the leader miss? Was the patient just not feeling like they could be honest with us? Did they, were they scared? Is it, something that we missed? I think it's something that we could have done better. I got a email today. I did not ask him if I could say a quote from his email, so I'm going to say it. I don't think he's here, but he talked about his wife recently was there last week, and he said something to me that stuck out to me, and that was, "You got it right." And I thought to myself, well, isn't that the truth? That's what we're after, is getting it right every time. So the bar is very high when it comes to each of you, as it should be. We are not any different than any other hospital. But the bar is always. It's not usually. I don't get credit for usually, and I don't get credit for never. I only get it if it's always. So we continue to find ways every single day. I could sit here for an hour. Cliff would pull me off. And I could go through all the tracking that we do of your feedback, of rounding every single day. What do we do with it? Questions are asked such as, did the staff treat you with courtesy and respect? If the answer is no, we figure out who it is and they get put on a list. on a spreadsheet. I have spreadsheets. And it's not to fire somebody, but it's to go back and say, hey, this is your third time that I've seen your name with the same kind of comments. Let's have a conversation. Well, they actually have a conversation after one, but a third conversation's going, that it's just something different. It is also, was it quiet enough for you to be able to rest last night? Do you know what I still hear? Your staff sounded like they were having a party out in the hallway last night. So we have purchased Yacker trackers. If you don't know what that is, it's like the stop sign, and it will buzz if they get too loud. You would think that our patients would be able to rest. So we are working on very specific things to try to create. I don't want to say it's home because it's not home, but even if your food is cold, what are we going to do about it? If you don't like your nurse, well, what am I going to do about it? There is, that your feedback is crucial for us. It doesn't have to be good. I mean, the good is great. I get a lot of great, but really it's just trying to work on that next step because it's important. It is something that hasn't been done right, I think, for many, many years. I do, and I know that somebody's going to ask me, so I'm just going to say it now. We most likely will still be a C in the spring. Okay, a solid C. In the fall, if I look at the calculations, we're very close to a B. I'm not going to say that we're going to be a B. And the one thing that's stopping us is some of the consumer feedback piece. The spring of 25, a B or an A. I mean, absolutely hands down. The work that we're doing now impacts us 2 or 3 years from now. So if you look at any of these, results, especially CMS 5-star, it's a cumulative 5-year. So I still have 2018, 2019 data that is now starting to fall off. But it doesn't mean that we're not giving great care today. But we still have to improve how we serve you when you come through our front door. So thank you. And I want to say it again, that we want to and we will get it right. Thank you.
Okay, questions? And Cheryl, while we're getting ready, just so you know, you have an invitation for next March, and we'll
Okay,
continue
great.
this.
Great.
because
Hopefully I'm
there-
not fired by then.
Well, you're not getting fired. You've done a great job, and there's great improvement been done in the hospital. It doesn't happen overnight. It was so bad that it took a long time to get it. As I said before, I haven't had a complaint in 6 months. I can't say. I used to get 1 or 2 every single week. So if you have a question, please raise your hand. Gary?
Not so much a question, but I'll predicate it by saying I've known Cheryl for a number of years. I remember when she was hired and first came in. And I have never met a person in my life who works so hard to try and make things so perfect. In the past year, the changes in that hospital, the staffing, the attitude, the atmosphere has completely changed. It's just like a family atmosphere. On the other hand, the focus is always the patient, always the patient. I never had to experience that. I've been lucky. I haven't been in the hospital. But my wife went in about a month ago, unexpectedly, in the ER. And I got to see it firsthand. And it was absolutely amazing. She was treated, and she said it right out to me. She said, I felt like I was with family. The doctor that came in, the nurse that came in, the medical technicians that came in, they paid so much attention, and they gave her so much care. And I thought, well, maybe that's just she's my wife and they know me. But then I started walking up and down the ER, and I saw the same thing happening with everybody else that was in there. Absolutely incredible. I've had drill sergeants that weren't nearly as tough as she can be, believe me. On the other hand, I've never seen anybody with such compassion and such drive. So in the past year, you have done a magnificent job. I hope and pray that people will please forget about things that happened 5, 6, 8 years ago. I get letters on stuff like that also. I'm also with the village as the chairman of District 5. But the long and the short of it is, it's a new dawn, it's a new day. Way they're going right now, we can be very, very proud of the village's hospital. And Cheryl, thank you for all you do, and particularly all your staff.
Thank you.
Over here.
Hi. When you say patients are seen by a leader every day, what do you mean by a leader?
It could be a charge nurse, it could be clinical coordinator, and it could be manager. Or it could be me.
I dittos for the accolades you've had. Absolutely better. The difference between a friend of mine's treatment in the hospital last April as opposed to this January, night and day. Could you give us some idea of all of the steps or requirements that are involved when a person is to be checked out and 6 or 7 hours later they still haven't left the hospital? What all is involved to get them out?
Sure, do you have an hour? No, I'm just kidding. So typically, what happens is you don't have just one physician, you have 2 or 3 or 4, right? So you may have your hospitalist, you may have your cardiologist or your pulmonologist. You could have a renal physician as well. So let's say that you go in and you have a cath done, just to look at your arteries within the heart. And he comes in and tells you, it's all clean, you can go home. And he writes in his little notes, patient is cleared. He's not the captain of the ship. He doesn't write the discharge order. He just tells you that you can go, and he writes a note that they're clear to go. So then you tell us, or somebody tells us, and then we have to try to find that attending physician and or any other physician to come and discharge you. Is it ideal? No. We actually are starting work with this next month to try to tackle this. This is probably one of our largest feedback issues, and it's something that has to be addressed. I don't have a good answer for you today, but next year it'll be fixed. I promise. I promise.
Thank you for coming. It takes a lot of courage to come back every year and have people throw darts at you. And this isn't a dart. I'd like to ask you this 3-part question. Number 1, are you in fact short-staffed? Number 2, I'd like to know your RN to patient ratio. And number 3, I'd like to know how close are you to the optimum level of staffing?
Okay, let's start with number 1. What was the question again? Sorry.
Are you in fact short-staffed?
We are not short-staffed. Short-staff, I think that's a loose term. I don't know what that, because of what you may say is short may not be what I say is short. Now we have staffing standards. Yes. Now, are there occasions instead of having five patients, they have 6 because we had 4 to 5 nurses call out? Yes. Does that happen? Yes. I'm not going to say that it doesn't. And then the second question.
Second part of the question is, what is your RN to patient ratio?
So critical care is 2 to 1, and then PCU is 3 and 4 to 1. CMU or like cardiac care is 5 to 1, and then the medical surgical observation is 6 to 1. Now sometimes that they can go up to 7 to 1, and that's if we get a bunch of call-offs, but we want to, and the budget is set for them to stay at 6. And that's why it's important for us to have techs. That's why that hiring 84% more is key, because having two techs for 50 patients doesn't do anybody any good. Having 1 for 7 or 8 patients means, that's the difference for the whole shift.
Okay, we're here in the back.
Yes.
Thank you for coming. I enjoyed your speech. I wanted to tell you that I just spent 5 days in the Villages Hospital. I went in through the emergency room and I came out walking. And I had a quality experience. I had so much attention, quality care. The food was good. I have no complaints whatsoever. I just thought you might want to know that.
Do you mind telling me which unit that you
I
were
was
on?
I was on medical unit. I would imagine I was on the second floor. I had so many people coming in my room all the time, always asking me what I needed. Was it too noisy out in the hallway, or all kinds of stuff all day long.
That's great. No, I did not pay her to stand up. Thank you.
Okay, well, mine's not so sweet.
Okay.
Okay, can you hear me?
Yes.
Okay, what hours do you discharge people?
It could be any time.
Okay, so at 4:30 in the morning, not calling the family, family's not aware, they call him some kind of a ride or something, take him to his nursing home, nobody was there to accept him, they didn't know he was back in his room, he fell because he was too weak and shouldn't have been dismissed that quickly without the proper evaluation. And she said the care was good otherwise. She couldn't come tonight because he had to go back in the hospital when he fell. He went to Leesburg, said, no, we're not taking him back to the Villages because of the way they did it. She had been calling, trying to get information as to when he was going to be discharged. But 4:30 in the morning, my husband's a traveling nurse.
One of those evil people, yes.
Yeah, he just came up from Fort Myers for this meeting.
Yeah, so here's what I would say. At 4:30 a.m., I'm not sure what happened. So if you can do me a favor afterwards, if you'll come up here and I can give you my card and let's talk, because I would like to better understand, because that's not normal. I mean, that's not what we normally do. And I would say that for any of you. If you're there or if you have a loved one that you don't believe that something's right, always reach out. Cliff has my cell phone number. You could probably find it if you Google it. I'm pretty much everywhere. So please reach out. But if you can talk to me after, which is so that I can take some time to look at.
Well, I just wanted to also mention that she was trying to get the status on his condition, and she was on hold and couldn't get through. And then the next day, their phones were down.
Okay.
So phones are down? Really? And you would discharge somebody without letting the family know?
Yeah, I believe that we should, of course, talk to the family. I can't speak to this case, but I'm more than happy to take time to review it, and then I can provide feedback.
Okay, I've got one for you, if I may. Sorry,
Yes.
Cliff.
Oh, yes, say.
My wife was in the hospital there, my late wife. One time, she was admitted, and it took 48 hours for her to get out of the ER to a room. Another time, she was in the ER with 82 other people. I'm not talking about the waiting room, I'm talking about the ER itself. They were stacked in lounge chairs, and I had all the HIPAA data on 4 people around, whether I wanted it or not. I thought about calling that in, but I didn't want to get you shut down. What are you doing to prevent that? Oh, and by the way, they refused, with 82 people in the ER, they refused to divert.
And this was recent?
That was about a year ago, year and a half ago.
Okay. Well, we have not had that case within the last year or two. So if the ER gets to a certain threshold, we now have a command center where the ER director does a I need help call, and we all get together to try to figure out what to do.
They refused to divert with 82 people in the ER.
Well, I can't speak to that last year.
More recently, in the last year, my husband was a guest of your hospital 3 times, and once was in the ER. And I'm a nervous Nelly because he has Parkinson's. None of those times was he hospitalized for Parkinson's, but Parkinson's patients require special treatment. All I had to do was say the P word, and they were on it. And I had all sorts of precautions. I even made up a big sign for his bed saying that he had Parkinson's, but they didn't need it. They knew exactly what to do, or if they didn't, exactly where to look for the medications that were contraindicated, etc. We moved here from Atlanta 2 years ago, where there's some really fine hospitals. We have absolutely no complaints. It was world-class care. The only thing that I might complain about, and that's just because I'm an architect and aware of aesthetics, is I don't like the color of the hospital gowns. But otherwise, we are confident. Thank you, Cheryl.
Something nice. 2 Saturdays ago, my wife playing pickleball broke her hip, and went to the ER. The following Sunday, your new Dr. Collins did surgery, did very well. We were extremely pleased with the OR. Her care in the hospital was great. Food was very good. The PTs that she had during the week, twice a day, were excellent, and I think it really helped her recovery. So very complimentary on the care she had.
Cheryl, thank you for your transparency. It's not always easy to stand there and talk about the good and the challenges. Your stats that you shared, you hired 428 nurses over what period of time?
Over the last year.
Just in 1 year?
Mm-hmm. Yes,
That's
ma'am.
very impressive, and as a result, you reduce your turnover
Right.
rate. You said that you have a 24/7 critical care provider. What specialty?
Critical care.
Intensivist?
Yes.
Thank you. You also said that the hospital has a C rating. You're hoping to go to a B rating by spring or end
Spring
of this
25.
calendar
Mhm.
year?
Spring of 25.
Okay, so for Leapfrog, what are you concentrating on?
Going to a BNA.
In what specialty areas and what focus?
Well, actually, the thing that we have to improve is patient experience.
So are you using Press Ganey?
Yes. Mm-hmm.
And how are you benchmarking yourself?
We're benchmarking against community hospitals.
Of like size?
Mm-hmm. Yes, ma'am.
What is your bed occupancy rate now?
Well, we've been about 94%.
Are you?
Mm-hmm.
Thank you.
So I will say that we have, like 306 beds. We also have 30 beds that are in patient rehab beds. The hard part about the winter is getting into surge like this, because then we are pushed into semi-private rooms. Nobody likes to be in a room with somebody else. So we're hoping that it calms down soon so that we can go back to private rooms. Yes, ma'am.
Thank you for coming, Cheryl. I have a question about the staffing. You mentioned the nurse to patient ratio.
Mm-hmm.
And you're saying when there's call-ins,
Right.
then it's not going to be optimal staffing. We understand that. What is your policy procedure in order to make up for staff call-ins and make sure that the staffing is as optimal as possible?
Well, the best news is that Leesburg and the villages share staff. So we do have a pool of staff, and they have signed contracts, and they go between the hospitals to help with the flux back and forth.
So if somebody were to call in, say, a couple hours before their shift, you can usually replace that person?
Yes, and if it was to go above what we would consider to not be okay, that we had talked about going above 7, well, then the leader has to come in.
Very good.
I got one.
Oh, yes.
I worked for over 40 years as a CFO with 3 different hospitals in New York. And I want to commend you on the progress you've made. I know it's not easy to make progress. You've done really well in the last couple of years, and keep up the good work.
Thank you.
You have a question?
Okay, thank you, Cheryl.
Oh,
As
that's-
always, she'll stay around in case you have some questions you want to bring to her. And if that lady would come and give her some more information, I'm sure she'll get to the bottom of it. If any of you want to contact her and you can't, you can call me. As she said, I do have her cell phone number, and I'm more than willing to give it to you. And she answers every call, every time I call. And as I said, mark your calendar for the third Tuesday in March 2025. We have donuts and coffee in the back. Thank you all for coming.